Welcome back. Today we'll be discussing Chapter 13, which covers vital signs and monitoring devices. This is one of those chapters where really hands-on helps seal all this information in. So we might be flying through a few of these slides, especially ones that go step by step on how to do certain types of vital signs or use the monitoring devices. And that's just because it's a lot easier to do this in person. So if you ever want more practice, feel free to come to me and we'll do this all in person. That's really the meat and potatoes of this chapter is in-person stuff. So we're going to be talking about how to gather vital signs, as well as the typical normal vital signs ranges we might see in adults. We did cover this briefly in lifespan development, but we're going to be focusing a lot more on the normal ranges of adults today. So vital signs are the baseline measurement that we get on our patients. This will tell us a whole plethora of information about how the patient is doing. Everything we've been discussing up till this point with the cardiovascular system and the respiratory system, all of the things that affect those will affect the vital signs. So our vital signs are a gauge to tell how well our cardiopulmonary system is functioning. So it's an outward sign of what's happening internally. And our vital signs will help us predict what might happen to the patient or give us a good gauge as to what is currently happening to the patient. This is something that we want to be getting on pretty much every patient we encounter. There are a few slim examples when we don't gather vital signs, one of which is if the patient adamantly refuses for us to do that. That is very rare that a patient refuses any sort of vital sign taking. And another one that is very rare is if the patient is too severe to do vital signs. An example of this would be someone who you are actively managing the airway, because in your primary assessment, you find that your airway is not open. So you are actively managing this. And if that takes you from the start of patient contact to the end of patient contact, because you're dedicated and stuck on managing that airway, then no, we do not want you to take other vital signs. We don't want to know what the blood pressure is or the pulse is if you can't spare the hands or the time away from the airway or some massive circulation problem to get those, because we need to focus on our ABCs before we move into vital signs. Again, that is incredibly rare. Typically, it's more than just you on a scene. It's more, and if you have a critical patient, it's going to be more than just you in the back of an ambulance. So usually we have the hands and the time to obtain some set of vital signs at some point, but there are some very rare instances where we have to prioritize our ABCs in front of this. That's why we separate our assessment into primary and secondary assessment. Getting your vital signs and the actual specific numbers come in your secondary assessment. If you remember back into your primary assessment, we do want to make sure a pulse is there, but we're not stopping for a long time and counting the rate. We just want to know if it's present, if it's strong or weak, not any more specific than that. So moving on into our actual vital signs. So the vital signs that we want to obtain on every single patient are our pulse, our respiration, your skin color, temperature, and condition, your pupils, and your blood pressure. These are things that we should be obtaining on every single patient for vital signs. So we have two different types of vital signs. First one is called our baseline vital signs. And that is the first set that we get. So that is what we are basing the rest of our vital signs off of. I say that because if the first set that you get, you have a heart rate of 100, and then second set, you have a heart rate of 150, then you know that from your baseline set, you've gone up 50 beats per minute, something has changed with the patient. If your first vital sign is heart rate of 150, your second vital sign is heart rate of 152, then that's not too much of a big change from your baseline. You know the patient hasn't changed much in your care. So that's why we have to get a baseline set of vital signs. In terms of repeating your vital signs, that the frequency will be determined on the severity of the patient. For our very critical patients, we want to be obtaining or repeating vital signs about every 5 minutes. And for our stable patients, so our critical patients, we can go up to every 15 minutes. We never really want to be assessing vital signs for a period longer than 15 minutes apart. And under 5 minutes, typically there won't be enough time to have a massive change. I say all that knowing that medicine doesn't have black and white rules. There's some times when patients change instantly, and if you have a noticeable change in patient condition, even if it's been 1 or 2 minutes since your last set of vital signs, you should reassess your vital signs then. So anytime that you see a change in patient condition, we should be reassessing our vital signs regardless of how much time has gone by. So diving into the specific vital signs, first one we're going to be talking about is pulse. The pulse is what you are feeling for to measure your heart rate. And the way that we measure it is you actually put your fingers on top of an artery. And when you put your fingers on there and you compress just a little bit, you're going to feel the actual pressure wave of your left ventricle contracting. And that moves blood in a wave through your arteries. So if you compress it slightly, you're going to be feeling that pressure wave against your fingers. So that's how we obtain a pulse. So the textbook way to assess your pulse is you want to find whatever artery you're using. We're going to be talking about the different arteries in a minute. And you want to feel for 30 seconds. You take the number that you get for 30 seconds, and then you multiply that number by 2. And that number that you get is going to be the heart rate for the entire minute. Now, you might see more experienced providers feeling for much less than 30 seconds time. And that's because with time and experience, you start to get a better feel for heart rates and be able to determine it more easier. So you might see an experienced person feeling a heart rate for 15 seconds or possibly even 10 seconds. But we really want you, when you're starting and learning, to feel for 30. And the longer you feel for a heart rate, the better that you're going to feel if you have missed beats or if it speeds up, slows down, which we call irregular. So it gives you a lot more time to actually decipher the regularity and the quality of your heart rate. So we really want you to start at counting for a full 30 seconds, then multiplying that by 2. So the normal heart rate for an adult who is at rest is between 60 and 100 beats per minute. And if you think back to our anatomy and physiology in the heart, if you remember the SA node, that's the node that everything for the electrical system starts with, the inherent firing rate of that SA node is 60 to 100 times a minute. So if everything's functioning normally, our impulse should come from that SA node, which wants to fire at that range, and that happens to be the range that our normal heart or pulse rate should be, 60 to 100 beats per minute. In the event that you have a heart rate that is above 100 beats per minute, that is above the normal heart rate that we should have, so we call that tachycardia. So remember, back to medical terminology, we have tachy as our prefix, which means fast, and cardia, which means heart, so fast heart. So again, that is anything that is above 100 beats per minute. Anything below 60 beats per minute is called bradycardia. Again, going back to medical terminology, the prefix brady means slow, and cardia means heart. So slow heart, that's below 60 beats per minute. In case you haven't been able to tell at this point in the course, medical terminology is not going away. So just because someone's heart rate is above 100 doesn't mean that it's a critical finding. Or if it's below 60, doesn't really make it a critical finding. We have kind of a buffer window. Usually we start to worry around 120 beats per minute and above for a fast heart. So between 100 and 120, it's kind of our cushion. That's our, okay, the body's doing something, but it's not in trouble yet. Same with on the low end, going between 50 and 60, that's our cushion. So if you're in the 50s, we keep an eye on it, but we aren't really worried. Once it drops into the 40s or below, that's when we start to think this is a pretty significant finding. You do also have to keep in mind When someone is in an emergent situation, one of the basic responses that your body does is crank up your heart rate. You should remember that from pathophysiology. One of the first things that your body does to start to compensate for something is to increase that heart rate so your blood moves around faster. So it is pretty common for us to see people with more increased heart rates than someone who's just sitting down watching a EMT class lecture. So if you see someone between 100 and 140 beats per minute, start to think about the circumstances surrounding it. Is the person nervous because they're having abdominal pain? Is the person breathing a little bit faster? Try to think of what the body might be doing to respond to whatever you're seeing, and have that kind of affect your decision making when you're assessing a patient as to how critical of a finding is your heart rate. If you can justify someone having a heart rate of 130 because you know what's going on in the body as a natural response, that's much less of a significant finding than someone who's just sitting there talking to you, nothing else seems wrong, but their heart rate is 130 for some reason. That's a much more significant finding. So take everything in context with the rest of the patient. So think about a few different situations that might make the heart rate outside of your normal range. So one of these common situations is someone who's exercising. When you're exercising, your body needs to move blood around faster, so your heart rate goes up. That's actually something that we try to do when we're exercising, to get your heart rate up. On the flip side, someone who is in a deep sleep, your heart's going to slow down a little bit because there's less demand on the body. So if you find someone who is sleeping, their heart rate's probably going to be a little bit below normal. If you find someone who just exercised or is in the middle of exercising, they might have a heart rate of 150, 160, and that's not something to be concerned about. So again, take everything into context when you're looking at vital signs. This is why it's so important that we know what the body does in certain situations. That's why I talk about pathophysiology. That's why we talk about half of this course, is knowing what's happening in the body so that we can see the changes and know if it's normal or not, if we have to treat it or not. So when we assess a pulse, the first thing we want is the rate. So that's how fast it's going. The second thing that we want is the quality of the pulse. So when we're talking about quality, we're looking at two different things. The first thing that we want to look at is our rhythm. Is the pulse regular or irregular? Does it march out a beat every second? So 1, 2, 3, 4, 5. Or does it change? Does it go 1, 2, 3, 4, 5, 6, 7, 8? So we want to find out if this is going to be marching out regularly or irregularly. And that's why we want to be feeling for a long time so that we can feel if there's any changes. So the two things that we call a pulse quality are either regular or irregular. Then we look at the force. So the force is how strong that wave is against your fingertips. So a normal pulse should feel strong. There might be times when the patient's blood pressure is low, and if patient's blood pressure is low, the heart's not pushing out that wave as strongly, so it might feel weak. So those are the two terms that we kind of look at when we're looking at the force. It's either strong or weak. Sometimes a provider might say that a pulse is thready, so that's when the pulse kind of feels weak and thin together. Usually that happens when the heart is already going really fast, and it's especially common if the heart's going fast and it's beating irregularly. So you can have a pulse of 140 that is irregular and thready, would be one way that you say something. A normal finding would be a person with a pulse of 80 that is strong and regular. So whenever we take a pulse, we want to know how strong it is and how regular it is. Anytime that you take a pulse, that should be coming out, the strength and the regularity. So some common pulse locations. And again, this is where it's a little bit easier to show in person. The first one that we look at, and this is the one that we typically will assess, is your radial pulse. The radial pulse is for anyone who's about 1 year of age or older. That's where our go-to as EMS providers is. It's the one that's on your wrist. So if you go from just above your thumb, you have your radial bone, and your radial artery runs on the inside of that radial bone. So if you feel your wrist and you feel on the thumb side the bone, and then you roll into a small soft spot right on the inside of that bone, you should start to feel a pulse. Now, when you're feeling any type of pulse, you want to be pushing in with a little bit of pressure, but not too much. If you push in with too much pressure, you will completely occlude the artery, and there won't be any blood flow going through there, so you won't be feeling those waves because you can't push past your fingers. So you want just enough to slightly compress the artery, but not enough to fully compress the artery when we're talking about pressure. So radial, like I said, that is our go-to as EMS providers where we're checking the heart rate. But you have to keep in mind that the radial pulse will not be able to be palpated if the patient's systolic blood pressure goes below 80. So the patient can be conscious, alert, and talking to you with a blood pressure below 80. Usually they aren't going to be feeling well. But you have to keep in mind that if it's below 80, you might not feel a pulse there. That's why you have some alternate sites. The next pulse area that we want to be talking about is your brachial pulse. Your brachial pulse is located in your upper arm along your humerus. And if you kind of feel in the middle of your upper arm, and you go between your bicep and your tricep so you can get to the long bone there, that's your humerus. And then you roll on top of that bone towards your bicep. That's usually where you should be able to feel your humor or your brachial artery. This is a artery that we want to be using for someone who is less than 1 year of age. One of the biggest reasons behind that is when you're less than 1 year old, your blood pressure is probably not going to be above 80 very much. And if you remember your radial, you lose around 80. So your brachial is going to be a lot better of a measure. You should be able to feel it in most kids. It's a lot easier to feel in kids because they don't have developed biceps and triceps like adults do. So there's much less tissue to feel around. So brachial is our go-to for kids less than 1 year of age. Here's a picture of a provider feeling for the brachial pulse. All right, the next one we want to talk about is the femoral artery. The femoral artery runs along the femur, and the best place to feel this is right where the leg meets the torso. You should be able, if you push really hard, start to feel your bone. And then if you roll onto the inside, so medially towards you, you should feel your femoral artery bouncing against your fingers. Femoral is harder to feel than most of the other pulses. And one of the biggest issues behind that is people have a lot of fatty tissues. If you have someone with very large thighs, it's kind of hard to feel through that fatty tissue to get to the femoral artery. The upside of the femoral pulse is you should be able to feel it at blood pressures above 70 millimeters of mercury. So you lose your radial at 80, but if your blood pressure is above 70, you should still be able to feel your femoral. So you should feel it for more critical patients that you might not be able to feel your radial. Then the last place that we check for a pulse is your carotid artery. This is the one that we teach 5-year-olds where their pulse might be. You feel your actual carotid artery, which is in your neck, and if you go to your trachea and then kind of roll onto the or laterally from your trachea, you should feel a soft spot, and you should start to feel a pulse around there. So that is your carotid pulse. This is the one that we can feel at the lowest blood pressures because it's very close to the heart. So we can feel this with any blood pressure that is above around 60 millimeters of mercury. So I do need to put a disclaimer. These numbers of 80 for a radial, 70 for a femoral, and 60 for carotid. These come from advanced trauma life support teachings. There have been several recent studies that suggest that these actually might be a little bit too high of numbers, that we should be able to feel these pulses at slightly lower blood pressures. So that's still being debated and studied, but we'll still teach this to you as a general rule of thumb. So this is not written in stone. It is currently being researched, but these are some general guidelines to kind of help you. And the big thing to remember from it is you will feel your carotid when you might lose your radial, and you might feel your femoral when you might lose your radial. So this is why when we have someone who we're checking just to see if they have a pulse, so someone who's presenting unconscious who might not be breathing, and we want to know do they have any sort of pulse, this is why we check for the carotid, because we don't want to take the guess that the patient might have a blood pressure that's so low that the radial can't be felt, but the carotid does, and then we start CPR on someone who has an actual pulse. So this is why we go straight for the carotid on someone who we are questioning if they have a pulse, period. So again, when we're checking for a pulse, you want to be counting for 30 seconds, and then multiply that number by 2. That should give you your minute-long pulse. If for some reason you find something that's very abnormal, so if your rate, rhythm, or force is not normal, you can always continue to count for a full 60 seconds to give a much more accurate picture of your heart. And again, you might see some more experienced providers counting for less than 30 seconds. As far as you guys go for being in class, 30 seconds is our standard. We don't want to go below 30 seconds because we really want a good picture of that pulse. So just because you see other experienced people doing it doesn't mean that you should be doing that quite yet. So moving on into your respiratory rate. So I will apologize right now. Medicine can sometimes be a little confusing. This is one of those instances. Up until now in class, respiration has meant the exchange of gases. And for any other part of medicine, that's what respiration means. But when we're talking about vital signs, respiration means the physical act of breathing in and out. So for the rest of class, that is what ventilation is called. But for just vital signs, if I ask for your respiratory rate, that is the amount of times that you're physically moving air in and out. So just like with pulse, when we're measuring our respiratory rate or respirations, you are looking for both your rate and your quality of respirations. So your respiratory rate, just like your heart rate, is the number of breaths that you take in 1 minute. The rate we can sometimes classify as normal, rapid, or slow. And if you think to our medical terminology again, we have actual medical terms for rapid or slow breathing. One of the most common ones that you're going to see is the one for rapid breathing. So if we think rapid, our prefix for fast or rapid is tachy, and the prefix for, or the root word for breathing is pnea. So rapid breathing, medical terminology would be tachycardia. Very hard word to say for me for some reason. If we have slow breathing, slow, our prefix is Brady, and we have the same root word. So we could have bradycardia. That's a more uncommon way to say it. We usually say that the respiratory rate is very slow, but you can always put medical terms to what we're talking about in medicine. So the normal rate for an adult that's at rest is 12 to 20 breaths per minute. So again, that is a normal adult range, 12 to 20. Anything above is considered fast, anything below is considered slow. Same idea with your pulse. We have kind of a buffer area. So just because someone is breathing 22 times a minute doesn't mean that that's a significant finding. Just because someone's breathing 10 times a minute doesn't mean that's a serious finding either. And then you also really have to look at your patient, just like with your pulse. If the patient just finished exercising, you're probably going to be breathing 30 times a minute. That's okay. That's your body doing what your body's supposed to do. If you have someone who's in a deep sleep or is very, very relaxed, they might be breathing at like 8 times a minute. That's okay. So take all these findings with context of your overall patient. And with that being said, keep in mind that the age, the gender, the size, the physical shape that someone's in, and your emotional state can all go into influencing your respiratory rate. So if you have a 400-pound man who is very much so out of shape, and he walks up one flight of stairs, he's going to be breathing 30 to 40 times a minute. He is going to be winded at the end of that. Versus if you have a 25-year-old female who weighs 190 pounds and goes up the same flight of stairs, you're going to have her at a relatively normal respiratory rate. She should probably be around 18. So take everything with context, both with your pulse and your respiratory rate. And again, this is why we teach you about everything behind the curtain with the body, so that we know what the body is doing and why it's producing the numbers that we're seeing. So when we're looking at the respiratory quality, so again, we want our rate and our quality. Quality, we can look at different types of categories. So you can have, and these categories look at your effort. So you can have normal effort. You can have shallow effort, so when you can only take a very shallow breath. You can have labored, where it looks like you're really struggling to breathe. Agonal, which if you remember back into our primary assessment, agonal respirations is something that is not effective at all. You can have distress, so someone who appears to be having a hard time breathing, or you can have no effort, so an absent effort, so that's no breathing. Usually you only see that with a respiratory rate of 0. So along with your effort, you want to be doing your rhythm. So you should have a regular rhythm. It shouldn't get faster, then slower, then faster again. Your depth should be the same. So they should be what we consider normal is respirations that are of normal effort, non-labored, and regular. So you can say that a normal person has a respiratory rate of 16 non-labored respirations that are regular. So regular non-labored respirations. As far as taking your respiratory rate, one of the easiest things we can do is assess it immediately after assessing our heart rate. We do that for 2 reasons. First, when you have your fingers on the patient thinks that you're taking their pulse. So if you have your fingers on the patient's radial artery for 60 seconds, you take the first 30 seconds and you count their heart rate. You take the second 30 seconds and you count their respiratory rate. The reason why we do that is because if you know someone is counting how many times you're breathing, you start to think about your breathing. And when you consciously think about your breathing, you consciously change how you breathe. A lot of people will either slow their breathing down or speed their breathing up. Whenever you consciously think about your breathing, it will typically change it. So if we have our fingers on the radial artery and someone thinks that we are still taking their heart rate, then we just change our gaze to look at their chest to count their respirations. We eliminate that bias that people might do when they know that they're having their respirations counted. So that's one of the main reasons why we can do heart rate for 30 seconds, then immediately to respirations for 30 seconds. Also, count respirations for 30 seconds, same benefits as the heart rate. You should, for starters, it only multiplies by 2, so your math is a little easier than if you're trying to multiply by 4 or 6. If you're counting for less time. And also, you can get a very good picture of the effort and the rhythm behind respirations, especially because your respiratory rate is usually much, much, much slower than your heart rate. So if you're counting for 30 seconds for a patient who has a normal respiratory rate, 30 seconds, they're only going to breathe 6 or 7 times in that 30-second period. So if you count for less than that, if you're only counting for, say, 15 seconds, you might only see 3 or 4 breaths taken in that time. That's not really enough to know if the respirations are fully regular versus irregular, or if the effort is changing. So that's why we try to count for at least 30 seconds. Again, a normal finding is someone with a respiratory rate between 12 and 20. So 16 is what we find in a lot of adults. And we look for non-labored effort and regular rhythm. So that would be a way that we'd say a respiratory rate of 16, non-labored and regular. An example of a not normal rhythm or respiratory effort would be a respiratory rate of 4, agonal effort, and irregular rhythm. So that would be someone who we actually have to ventilate. All right, so moving on into your skin. Your skin provides great information that is very easy to see and very quick to obtain regarding your circulation and how well your heart is doing at moving blood around. So when we're looking at skin, we want 3 measures. You want the color of the skin, you want the general temperature of the skin, and you want the condition of the skin. So for color, we want to be looking at places where our capillary beds are very close to the surface of your skin. So some of the best places that we look for skin color are our nail beds, the inside of your cheek, the inside of your lower eyelids, the outside of the lips, or the earlobes. Typically, me personally, I'm looking at the nail beds, the fingernail beds, and the lips. So some color changes you might see are pale, cyanotic, which that's a blue color. Cyanotic indicates that there's not enough oxygen in the blood, so you're seeing deoxygenated blood circulating around, which will turn you a little blue. Flushed, which is very, very red. Jaundiced, which is yellow. That usually indicates liver failure. Or ashen, which is a gray color. And ashen usually indicates little to no circulation whatsoever. That's something that we see in someone who's either dead or about to be dead. It means that blood is not circulating there really anymore. The normal color that we're looking for is pink. So a normal skin color is pink. And if you look down at your fingernails, as long as they don't have polish on them, you should see pink. Same with the outside of your lips. The outside of lips should probably be pink. So that's the color that we consider healthy is pink. The next thing that we look for is your temperature. And we're not talking about a thermometer temperature. We aren't talking about 98.6. We want to know, does it feel warm? Does it feel hot? Does it feel cool or cold? So we assess this by feeling the patient's skin, usually with the back of your hand or with your forearm. The reason why we say forearm sometimes is sometimes having your glove on, having that barrier, you can't get a good gauge of the temperature. So touching with the back of your forearm, which is skin-to-skin contact, might help you get a better gauge. I personally always say touch a patient with a barrier between you and them. So if you can feel it adequately with your gloved hand, that's perfect. That's my preference I want you guys to do, because we always want to have some sort of barrier between our contact with the patient. So here's a picture of someone taking a blood or a skin temperature with their forearm. Again, we are looking for hot, warm, cool, or cold, and the normal finding is warm. So the normal color is pink, and the normal finding is warm. Moving into the skin condition. When we're measuring the skin condition, we're really measuring how much moisture is on the skin. So the different findings that you might have are dry, moist, clammy, or diaphoretic. Diaphoretic means excessively wet. That is someone who is pouring sweat out. So that's diaphoretic. Clammy is a decent amount of sweat on there that you can kind of wipe off. Moist is just damp, and then dry, that is our normal finding. When you touch your forearm or the back of your hand, it should be relatively dry. So the three normal findings in skin is warm, pink, and dry. That is normal skin assessment. It's warm, pink, and dry. So when you're looking at pediatrics, especially for anyone who's under 6 years old, we also want to be checking what we call their capillary refill. So we talked about that a little bit with pathophysiology. So with capillary refill, you pinch their fingernail bed. So if you pinch your own, it should go white. And then when you release that pressure on the fingernail bed, it should return to pink. You want to count how long it takes for it to return to pink. And the normal finding for capillary refill is it should return to normal color within 2 seconds. So you want to have it less than a 2 seconds change. If it's longer, you can call that delayed capillary refill. Delayed capillary refill usually indicates poor circulation. So that could usually be lower blood pressure. And this is especially important in our very young kids that might be hard to actually obtain a real blood pressure on, especially our toddlers who won't stay still long enough to get an adequate blood pressure. So this is another measure that we can use to know, are we perfusing correctly? Remember, perfusing from pathophysiology, that means that your cardiopulmonary system is working the way it should. So less than 2 seconds usually means that you're perfusing pretty correctly. So this is a gauge, again, with younger kids we can use, especially ones that it's hard to get blood pressure on. Or if you need a very, very, very quick measure of how someone is perfusing, this will help you get a very baseline measure of, are they perfusing okay or not. So this is something you should absolutely follow up with a blood pressure, but if you need to know in 1 second how are they perfusing, capillary refill will help determine that. It's not an end-all be-all, but it's a nice tool to add to your toolbox. So moving on to pupils. Pupils, we should all know, it's the center of the eye. Pupils change in size based off of the amount of light in a room. So if you have a dark environment, you should have a dilated pupil, so a bigger pupil. If you have a bright environment, pupils should constrict. So a few things that we look at when we're checking pupils. You want to know what the size of the pupil is before you shine a light into it. That is your baseline size. So you should have relatively around 3 to 4 millimeters is a normal pupil. But just look, is it overly dilated or is it overly constricted before you start shining a light in there? And you should note that. Does it look kind of like most people's pupils should, or does it look really big or really small? When we're shining a light into pupils, cover one eye while you shine a light into the one that you're assessing, and then you repeat the other side. And there's a few things we're looking for when we're doing that. So the three things that you want to be looking for with pupils, you want to check for their size. So we want the baseline size. You want to know if they're equal, so if they're round and if the left side is the equal or same size as the right side. And you want to know the reactivity. So when you shine a light into it, does it get smaller? Does it constrict? That's the normal reaction to light being shined in your eyes. And that will help us determine how our neurologic state is. So here's a few examples of pupil sizes. The top one are constricted pupils. You might hear someone say pinpoint pupils because the pupil represents the size of the pinpoint. This middle one is dilated pupils, so ones that are very large. And then the bottom one is unequal pupils. That's where one is large, one is tiny. When you see someone with unequal pupils, that can be a very significant finding. It can sometimes be the result of someone who's taken drugs, someone who's had eye drops put in that will constrict one side or dilate one side. Or it could be the sign of a serious neurologic finding. Sometimes someone who is having a stroke and is having A lot of problems with their brain might have unequal pupils, and that's a very significant finding. But sometimes there are a few people that is their baseline. My grandfather, for example, his baseline is one is constricted, one is dilated. That is how he is at all times. So if you find someone like this, feel free to ask them, is this normal for you? Because sometimes the answer might be yes. Here's an actual example of someone with unequal pupils. So you can see one is constricted and one is dilated. So moving on into blood pressure. Blood pressure is how much force the blood is pushing against your arteries in your body. So that's the amount of force that your heart is spewing blood out with. We have two different measures of blood pressure. You have your systolic blood pressure and your diastolic blood pressure. Your systolic blood pressure, that is your top number. If you ever hear someone say blood pressure might say 120/80, your top number is going to be your systolic. Your systolic will always be higher than your diastolic. And systolic measures the amount of force that's put on your arteries when the heart actually contracts. So when the blood exits out that left ventricle, that is your systolic blood pressure. It's the most force your arteries have to withstand. Your diastolic blood pressure is the pressure that is constantly in your arteries. So that is the pressure inside your arteries when your heart is at rest. It is not contracting, it's refilling with blood. So both of those are important to know because systolic will tell you how much top force your arteries are under, but your diastolic tells you how much constant force your arteries are under. So if your diastolic is raised really high, then it will tell you that your arteries are under a significant amount of constant force, which is going to start to weaken the walls. Usually it will weaken the walls very quickly. Systolic is important to know because if the heart is pumping so hard, it's pushing so much force against your arteries that your systolic is jacked up to say 200, then we know that the force going in your arteries is so big that it might burst the artery. So any changes from normal blood pressure, so normal blood pressure is systolic, no more than 120, but you want it more than 100, and diastolic, no more than 80, and you want it more than 60. So your normal ranges are systolic of about 100 to 120, and your diastolic around 60 to 80. So any changes from the normal range might indicate something very significant. For high blood pressure, we're going to start to see symptoms such as ringing in the ears, a headache, blurred vision, and you're thinking that an artery might rupture because it's under so much pressure that the walls can't contain that amount of pressure. So that's the problem with high blood pressure. If we have low blood pressure, on the other hand, that might indicate that the heart's not pushing blood out with enough force for it to actually circulate and perfuse our cells. So you might have hypoperfusion, which, if you remember, hypoperfusion is another word for shock. So low blood pressure can very easily turn into shock. So that's why blood pressure is very important to know. And when we measure blood pressure, we measure the pressure in millimeters of mercury, mmHg. So any measure of blood pressure is done in millimeters of mercury. You will most commonly see people not use those units. So you can say blood pressure is 140/90. That's a common way to say blood pressure, and the unit is assumed because there isn't another unit that we commonly use to measure blood pressure with. So keep in mind what the unit is, but it's generally acceptable to say a blood pressure is 130/80. So your blood pressure is measured with a blood pressure cuff and a stethoscope. The cuff of the blood pressure cuff should cover the 2/3 of the upper arm between your elbow and shoulder. So as you can see here, it's placed just between the elbow and the shoulder. You want a couple inches above the elbow. And most blood pressure cuffs have gauges right here, and this one says left arm with an arrow pointing down. The other one says right arm with an arrow pointing down. You want to line that arrow up just around the medial area of the arm. You really want to line up with the brachial artery, and that will just help the blood pressure cuff be in proper position so it is putting pressure in the right areas. So there's instructions here on how to take a blood pressure. This is something that's a hands-on application. So if you're struggling with this, feel free to see me in person and we will go over how to actually take a blood pressure. General rules: you want to put the blood pressure cuff on, make sure it's nice and tight. You want the center of the bladder placed over the brachial artery. That's what that line is for. You want to tell the patient you're taking a blood pressure because it is somewhat uncomfortable on the arm. It does put a lot of pressure on the arm. When you're putting the stethoscope on the patient, you should want to do it on the anterior side of the elbow. I usually go a ½ inch below the elbow. The reason behind that is if the patient's elbow is bent at all, you might not have full coverage of your stethoscope in that area. So going a little bit below, more into the forearm, you should still hear the blood pressure okay, but you don't run the risk of the patient possibly bending their arm and making it so you don't have good surface area of your stethoscope over the arm. So you want to inflate your cuff. Generally, when I'm teaching people how to do blood pressures, I tell you inflate your cuff to about 100 millimeters of mercury and stop there for a second. And the reason why is the majority of our patients, not all of them, but the majority of our patients will have a systolic and diastolic range that covers the 100 mark. So that means that your systolic shouldn't be below 100, so it should be above 100, and your diastolic should be below 100. It shouldn't be above for most of our patients. And what we're listening for when we take a blood pressure is the actual heartbeat coming through, because that's pushing through the pressure that the cuff is putting on the artery, and you're going to be able to hear that. You should hear that from the point between your systolic and your diastolic. So if you listen in between that range, you should hear the heart rate going. So the reason why I tell you to go to 100 and listen is that will help tell you, are you in the right area? What does it sound like for this patient? Because different patients might be a little bit softer, might be a lot stronger. So this will give you a good idea of what this patient might sound like at baseline. Once you hear it, so you know you're in the right position, you know what it sounds like, go ahead and inflate it above where you should lose hearing of the blood pressure. So usually around 150, 160. That's usually where we are going to have a good solid loss of our sound for a while. The textbook says to go about 30 millimeters higher than when you lose the sound. So try 150, 160. If you still hear it, keep on pumping up. Pump up until you can't hear it anymore. Then you slowly release the air from the cuff. And when you start to hear that beat come back, this is why it's important to know where that beat is before. When you start to hear it come back, that exact moment, wherever your gauge is reading, that is your systolic blood pressure. That is the amount of pressure that the heart is pushing out that can get past the amount of pressure that you're putting on that artery to occlude it. So that's your systolic blood pressure. You're going to continue to listen and hear that heartbeat until you can't really hear any sound anymore. The textbook definition is you listen for a change to a dull muffled sound, so there's a slight change in the sound. That really happens maybe 5 to 10 millimeters of mercury before you lose the sound altogether. So most people, especially in the back of a moving ambulance where it's hard to hear very fine changes, most people, it's okay to just listen until you can't hear the heart beating anymore. So that means that the amount of pressure that you're putting on the artery is less than the amount of pressure that is constantly in that artery. So there's no occlusion happening. so you don't hear the heart coming against any pressure anymore. So that is your diastolic blood pressure. So you want to know your systolic and your diastolic, when you start hearing the heartbeat and when you stop hearing it. So our preferred way of measuring blood pressure is by auscultation, so that's listening. So it's using the stethoscope and listening for those beats. There are instances where you can't hear those beats. That could be because the patient has too much fatty tissue. It could be a noisy environment and you can't do anything to get out of that noisy environment. Or it could just be your stethoscope can't hear that well. So in the event that you can't auscultate a blood pressure, we can palpate, which means feel a blood pressure. So we go through the same steps with the cuff, but you feel for your radial artery, then you inflate the cuff while you're still feeling for the radial artery. That radial pulse will go away once you have the cuff high enough, and then you start to release the pressure, and when that radial pulse comes back, that is your systolic blood pressure. Again, the pressure in the cuff is going to a level that your heart can push past it, and you're going to feel that pulse again. So that will tell you your systolic pressure only. So systolic is better than knowing nothing, but we really want to know our systolic and diastolic because the diastolic does tell us some more diagnostic information. Like I said earlier, pediatrics, especially infants, so people who are younger than 3 years old, they're really hard to get accurate blood pressures on. That's usually because they won't sit there and be still to cooperate for it. And pediatrics are hard enough to get a blood pressure on just because they're so small and things sound so quiet. So when we have pediatrics, especially infants, a lot of our useful information comes from how do they look. So do they look sick? Are they having respiratory distress? Are they conscious? Are they acting appropriately? Is their capillary refill okay? So we're using a lot of different other tools to measure do they look sick or not? And sometimes that'll be just as valuable as getting a blood pressure on someone. So be adaptive to your patients. So next vital sign is your temperature. Your temperature is an indication of if your body is doing okay, if it's maintaining homeostasis. So you have a core temperature. Your core temperature reflects the amount of heat inside of the trunk of your body. So trunk is from your neck to your legs. And it should be around 98.6 degrees. A little bit of variation up or down is normal. We're really looking for big changes. If someone's temperature is above 100 or if it's below 97, that's when we start to get worried that the body's temperature is not within normal range and the body might not be able to function properly if your temperature is too high or too low. Some things that you want to take into account when you're measuring temperature is the time of the day, the amount of sun that might be out, the activity level that just happened, your age, and where you measured the temperature. All these can affect the temperature that you get. So moving on into oxygen saturation. Now I mentioned oxygen saturation in our airway management section, section 2. It is a wonderful tool. It is not the end-all be-all of patient assessment or patient care. So oxygen saturation measures the amount of molecules that are attached to hemoglobin. So remember, hemoglobin are molecules on the red blood cells, and those are the magnets and carriers for oxygen. So the vast majority of the time, if a molecule is attached to hemoglobin, that molecule is oxygen. There are some instances that it is not oxygen. One of those instances is carbon monoxide poisoning. Carbon monoxide will stick to hemoglobin much better than oxygen will. So a normal range for a pulse oximeter readings, so your oxygen saturation, is between about 92 and 100%. You want that much of your hemoglobin occupied by oxygen. But if you have another molecule, say carbon monoxide on there, you can have a SpO2 reading, oxygen saturation reading of 100%, but only 50% of those molecules are oxygen. So that's why we have to take your oxygen saturation in context, just like the rest of your other vital signs. You need to think of the context going on. If you have someone who is being pulled out of a CO poisoning environment, oxygen saturation is not going to be a very useful tool for you. So that's one of the issues that you can have with oxygen saturation. And another thing that you need to be very mindful of is the waveform that you see in an oxygen saturation. So when you attach a monitor, it should have a separate bar that will go up every single time that the heart rate beats. And that should go all the way to the top. That is your waveform. That means that it has a good signal. If it doesn't bounce all the way to the top, that means it's not having a good reading. So your reading might be inaccurate somehow. So pulse oximetry use, it depends on your area and your department. Most departments in New York State, it is becoming a mandatory reading that you want to be taking on every patient. It, again, is a wonderful tool that can help assess the patient condition. It's not the end-all be-all, but it's a wonderful, wonderful tool that can help us tell if a patient is hypoxic or not. Even if you don't have a rule to use on every patient, you absolutely should use it on any patient that is having any sort of respiratory problem or anyone that you're suspecting might be hypoxic. Remember, hypoxic is low oxygen levels. Here is an example of a SpO2 device. Usually, SpO2 devices read your percent of oxygen, so that's SpO2, and it will read your heart rate. So if you see in this picture, you have 98, and that is your SpO2, so that's 98% of the hemoglobin is binded to, so we can say that oxygen saturation is 98%, and then the heart rate right here is 82. One trap people fall into that drives me up a wall to no end is they don't put their actual hands on the patient to measure a pulse, because they just put the SpO2 on and, oh, well, the SpO2 monitor is giving me a heart rate, so I know the heart rate. But if you remember back to in this lecture, when you're measuring vital signs, you have to measure your heart rate, rhythm, and quality. You have to know those other two factors, which this does not tell you. It will give you a number. It does not give you the information you need to know to determine, is it regular? Is it irregular? Is it weak? Is it strong? So these are reasons why we have to put hands on our patients. This is a trend that is very alarming, that a lot of our newer providers are not putting our hands on our patients. We gather so much information when we put hands on patients. So please get your heart rate manually first. Oxygen saturation, like I said, is a great tool, but we need to know our other vital signs before we look at our oxygen saturation. So when we're looking at the numbers that's going to give us, like I said, our normal range is around 92 to 100%. You have some mild hypoxia if you're around 89 to 91%. You have pretty significant hypoxia if you are 86 to 88%. And you have severe hypoxia if you're 85% or less. Typically, I tell people, if you have severe hypoxia, I don't need a tool to tell me that. You are going to see that on your patient. So if you have a SpO2 of 85% or less, you're going to see someone with significant respiratory distress problems. You're going to see someone that has cyanosis, that's the blue color of the skin. You're going to see someone who is in significant distress somehow. I don't need my tool to give me an exact number to know this person is in distress. Yes, this tool helps give us an exact number so we can know how bad per se it is, but look at your patient first. And also, if your SpO2 monitor is reading 80%, but your patient is sitting up there talking to you just normally, they're complaining of toe pain, take that into account. Your patient with a true SpO2 below 84% will probably not be presenting normally to you. So that means that your reading might not be accurate. These readings are very often not accurate. So some of the factors that might go into changing the accuracy of these readings. Shock is one of them, where we aren't circulating blood to the fingertips as well, because that's usually where you measure SpO2 is in your fingertip. Hypothermia is another one. When you're hypothermic, your body brings all the blood back to your core. And if you don't have much blood circulating around your fingers, then you're not going to have a good, accurate measurement of the amount of oxygen in that blood. Carbon monoxide, like I talked about, it will bind to an SpO or bind to hemoglobin, and it's going to read as 100% SpO2 when you are in a very hypoxic state. Excessive movement, if you are moving your fingers around and it can't function properly, that can affect the reading. Nail polish can obstruct the light going from one side of the SpO2 monitor to the other. Anemia, not having enough blood in your body, period, might affect these readings. So a lot of these things will give either lower or higher readings than what it actually is. So again, wonderful tool. It really is. It has done wonders to help us see how well patients are doing. But you also have to take things into account of the greater picture. So use that tool and take it into account with everything else that you're seeing. Don't just treat the tool. Treat your patient as a whole and use your tools to help you decide your treatment modalities. Moving on to blood glucose meters. Blood glucose meters, this is another one that's a lot easier to show in person. It measures the amount of glucose in the bloodstream. So the amount of glucose in the bloodstream is measured in milligrams of glucose per deciliter of blood. So mg/dl is the amount, or is the measurement that we're using. We use this to help identify people who are in diabetic emergencies. So whether they have too much glucose in their bloodstream or too little glucose in their bloodstream. Here's a picture of a blood glucose kit. So some things you want in your kit. Right here you have an alcohol prep to disinfect skin. You should also have 2x2 gauze to stop bleeds after you puncture the skin. Right here, this is called a lancet. These are safety needles. So there's a spring right here connected to a small needle that ends here. You take this blue cap off, so it spins off usually, so you spin and pull. And then this is your spring-loaded mechanism. So you put this end on the patient's finger that you want to poke, and then you push down on this, and that will activate the spring, which pushes the needle in and out of the skin, and that retracts, and it is a one-time use thing. So you can put that right into a sharps container, and the spring should never activate again. So we use this to actually puncture the skin. And here you have the strips that we take the blood sample with. A strip goes into here. This is the glucometer. So this is the actual thing that does the reading. So a strip goes right down in here. When you push it in, it should turn on for most models. And then there'll be a little blood collection site out of the strip right here. You touch that to the blood that you got from puncturing the skin. And that will give you your reading in a couple seconds. So some notes on glucose reading. You have to get permission from your agency's medical director in order to do blood glucose monitoring. In New York State, you actually have to have a laboratory license to be able to do blood glucose readings as an agency. So that's a whole separate license that you have to go through in order to use a glucometer. Not every agency has the laboratory license and permission from your medical director. If you do not have either one of these, you cannot do blood glucose monitoring. Your monitors must be calibrated regularly at Eves, where I work full time, we calibrate ours once a week. We have test solutions that we put a strip in, and we use the test solution instead of blood, and it's supposed to put it in, or it's supposed to give a reading in a specific range. That's our calibration to know that we are still reading the correct range. And we actually have a low solution and a high solution that we use for that. So these are the steps to do a blood glucose stick. I discussed a little bit when we were looking at the picture. And again, if you need help with this, feel free to see me in person to do this. So our normal ranges of blood glucose. Our normal range is between 80 and 120 milligrams per deciliter. So 80 to 120 is normal. We start to get concerned on the high end when we reach 300 or higher. So that's when we get really concerned that the blood glucose is too high. When we get above 400, that usually requires treatment. So that's where you're going to be calling for ALS to come in and start to treat the patient for that level. On the low end, 60 to 80, that's our buffer zone, just like the other vital signs kind of have a buffer zone. So 60 to 80, you're below normal, but we aren't in the treat you stage yet. Readings below 60, that's considered hypoglycemic. Remember our terminology, hypo means low, glycemic is glucose, so low glucose. So anything below 60 is considered hypoglycemic, and that's when we start to think about treating our patient. We're going to talk about that in diabetic emergencies. So just remember, our normal range is 80 to 120. We get really concerned above 300 and below 60. Those are our concern areas. And also, when we're talking about known diabetics, we're going to talk about this in diabetic emergencies, particularly on the high end. Ask them if they're diabetic, what are they normally running? There are some diabetics out there that do not manage their diabetes well, and they are 400 and above for their reading every single day for months or sometimes years. My grandmother, who is a diabetic, went probably 3 to 4 years with no treatment whatsoever, and she would read 400 to 500 every single day. So when you find these people that have very high readings, ask them what they normally are, even if it's not to the 300 level. Say their blood glucose is 220. That's still very high. So ask them, what are you normally? Are you normally in the 200s or are you normally 80? And that will help determine how abnormal of a finding this might be. So when we're talking about any type of vital sign, age is one of the most important factors in knowing, is the vital sign normal? That's why we talked about lifespan development before this. So remember, from lifespan development, infants and kids have faster heart rates, faster respiratory rates, and lower blood pressures. So knowing those ranges is critical for adequately assessing pediatrics. A heart rate of 150 in a 1-year-old is not nearly as significant of a finding as a heart rate of 150 in a 90-year-old. So know your ranges. You don't have to memorize exact for every single month of life, but know your general ranges and know what's generally normal. That will help you miles when it comes to assessing your patients properly. All right, so going into some chapter review. You can gain a great deal of information about a patient's condition by taking a complete set of baseline vital signs, including pulse, respirations, skin condition, pupils, and blood pressure. The EMT must become familiar with the normal ranges for pulse, respiration, and blood pressure in adults and in kids. Definitely have the normal ranges for adults memorized, forwards and backwards. Kids have a general idea of the ranges. Trends in patients' conditions will become apparent only when vital signs are repeated. That is an important step in continuing assessment. That's why we take a baseline set of vital signs and then we repeat the vital signs. Again, the frequency we repeat them at depends on the patient condition. How often you repeat vital signs will depend on the patient's condition. At least every 15 minutes for stable patients, and at least every 5 minutes for unstable patients. Consider if there is time to obtain vital signs or if you must wait to obtain them en route to the hospital. That will come down to how critical is your patient. Consider when to apply a pulse oximeter. Should you apply it to a patient with difficulty breathing? How about without difficulty breathing? Generally nowadays, we're applying them to pretty much every patient, but definitely people with difficulty breathing. Consider whether abnormal vital signs are a result of an illness or injury or the result of some other factor happening in the body. So again, take everything in context with the general greater picture of the patient. So by now, you should be able to name the different vital signs we're looking for. You should be able to tell me why vital signs should be taken more than once. You should know how much time should the EMT spend looking for a pulse when the radial pulse is absent or extremely weak. How should you react when the blood pressure monitor gives a reading that is extremely different from previous readings, especially if you're using an automated blood pressure cuff? If you notice, I hadn't talked about automated blood pressure cuffs. That's because manual blood pressures are the best and most accurate way to obtain a blood pressure. So I want you guys taking manual blood pressures. How can you get an accurate pulse oximeter reading on a patient with thick artificial nails? Sometimes that's really hard to do. But if you go to other places that you find high capillary beds, like the ear can sometimes be used. Another finger can sometimes be used. Sometimes a toe might be able to be used. So places that have good capillary beds. Sometimes a patient's heart will have an electrical problem and beat more than 200 times a minute. Why is the pulse so weak in such a patient? So this is something that we're going to be covering a little bit more in shock and in cardiovascular emergencies. But when your heart is beating so fast, your heart doesn't have time to refill. Remember, we talked about preload and shock. Preload is the amount of blood that comes into the chamber during rest. If you don't have a long enough period of rest, you can't get enough blood into that chamber. You decrease your preload. If you don't have enough preload or enough blood in that chamber, when it beats out, you aren't going to be pushing enough blood out. If you don't push enough blood out, you're not going to have a significant or a sufficient blood pressure. So, like I said, we're going to talk about that a lot more with bleeding and shock and cardiovascular emergencies. But knowing that the heart rate is 200, which means you should see a lower blood pressure, helps you treat your patient better and expect findings a little bit more. So that brings us to the end of this chapter. I know we covered a lot, and like I said at the start and a few times through this, a lot of this is hands-on. By the time that we're done with this class, you guys should be masters at taking vital signs. That's why you have a vital sign tracker to where I want you taking vital signs on many people many times. That way it's second nature for you guys before you even become certified as EMTs. This should be stuff that you have down pat before you can become EMTs. So that brings us to the end. So until next time.